Hi, everyone. Thanks for joining us today. I'm Maggie McGuire, Senior Associate Director of Research Communications here at the Michael J. Fox Foundation. If you've listened to our webinars before, you may have expected our regular moderator, Dave Iverson. Unfortunately, Dave is not able to join us today, as he's helping the foundation in another way. Dave is actually climbing Mount Whitney in California with our resident endurance athlete, Sam Fox. No relation to Michael, I have to say. Sam's Tour de Fox is about two-thirds done. It's a 3-month excursion where he's biking and hiking his way across the country, climbing the highest peak in each state, which is what Dave's doing with him today. So we wish them well. And you can learn more about how you can support their efforts at tourdefox.org. But today we'll be guiding our experts through a conversation on a sensitive topic. We know that cognitive impairment is of great concern to people with Parkinson's and their loved ones, and it can be difficult to even talk about this symptom. So while we'll discuss facts and theories surrounding cognitive decline and dementia today, we just want to say at the forefront that we bring a lot of empathy and sensitivity to this conversation, and our slides and conversation topics have been vetted by close members of our patient community. So we hope you find our presentation informative, and we'll also be answering your questions. So you're able to submit questions throughout the hour, and our experts will answer those later during our presentation. You should see a question and answer box near the middle of your screen. Type your questions there, and we'll try to get to as many as we can. If we don't get to your question today, you can join us tomorrow on Twitter at 12 noon Eastern and use the hashtag FoxPDChat to continue our conversation on cognitive issues in Parkinson's. Also, we are providing the slides from today's webinar for download. You should see a box called Resource List, and the top link there allows you to open the document in a new browser window, and you can save or print from there. Finally, I have to say thank you to our Third Thursday's sponsors, Acadia Pharmaceuticals, Medtronic, and Teva. So, okay, let's see what we will cover today. First, we'll introduce you to some of the terms we'll use in our conversation. We'll cover what we know about who with Parkinson's may develop mild cognitive impairment and dementia, and what we see happening in the brain with these symptoms. Finally, we'll review available treatments and therapies and testing. Next, let's meet our panelists. Joining us is George Prescott of West Bend, Wisconsin. Thank you for being with us, George.
Hello, Maggie.
We also have my colleague, Dr. Jamie Eberling, who leads the Michael J. Fox Foundation's work in the fields of Parkinson's cognition.
Thanks, Maggie. Hi, everyone.
And here, too, is Dr. Jennifer G. Goldman from Rush University in Chicago. She's a practicing physician and has done extensive research on cognitive status of people with PD. Thanks for being here, Dr. Goldman.
Thank you, Maggie. I'm delighted to be part of this panel. Thank you.
Okay, so let's dive in and start with some terms. Dr. Goldman, many think cognition is synonymous with memory, but there are other aspects involved. Can you take us through those?
Sure. So, yes, absolutely right. I think when people frequently think about cognition or trouble with cognitive faculties, they tend to equate them with memory issues. But really, the concept of cognition is much broader than that. So cognition unto itself really refers to the mental abilities that are used to process information and apply this knowledge to the world around us. And it encompasses actually much more than memory. It can include other abilities that affect attention, making judgments or evaluating situations, reasoning, solving problems, making decisions, finding the right words to say, planning tasks. And in fact, many of these other areas that we see in attention or planning or multitasking are indeed even more common in Parkinson's.
How do we characterize mild cognitive impairment and dementia?
So mild cognitive impairment, or also sometimes referred to as MCI by its initials, we might see that in studies or in the literature, is really a clinical definition that we use to define when people are having cognitive troubles, whether it's related to Parkinson's or other disorders, but they're noted and they're mild, and they don't necessarily be severe enough to interfere with activities of daily life or their ability to live independently. Whereas dementia really refers to a syndrome where there are problems in cognition that affect several different areas, so usually more than one cognitive domain. So something that might affect memory, but also difficulties with visual spatial function or difficulties with executive function, which I think we'll talk about in a little bit. But they're of a degree that's severe enough to affect someone's ability to do their everyday activities. These terms are a little bit newer in Parkinson's, but they were drawn from studies over many, many years looking at aging and looking at another neurologic condition called Alzheimer's disease. But really our efforts in Parkinson's have been to try to define these syndromes and to find ways to improve our diagnosis of patients who might have these symptoms and to develop better treatments.
Understood. Talking about diagnosis, we might see on the screen now that we hear a lot about Parkinson's disease dementia and another type of dementia called Lewy body dementia. Jamie, can you explain to us the difference?
Yeah, so as it says on the slide, the real difference here is just in the timing of when the dementia occurs. So in Parkinson's disease dementia, the person is diagnosed with the motor symptoms, and the dementia symptoms appear more than a year after the onset of those motor symptoms. And it could be several years after the onset. It could be many years after the onset. Lewy body dementia, on the other hand, is a term that refers to the case when both dementia and the motor symptoms appear within 1 year of each other. So the person here becomes demented much earlier in time with respect to the motor symptoms.
George, we heard some of the symptoms that qualify as cognitive issues. You've struggled with multitasking. Can you tell us about your experience with Parkinson's and cognitive issues?
Yeah, for me, it came on gradually and really became aware of the cognitive side because it made such a difference before and after my DBS. But the ones that really tripped my trigger, the attention, memory, almost all of them, judgment, evaluation, reasoning, problem solving. For a while, I was in such a state I had trouble figuring out the tip on a dinner bill. I've pretty much grown out of that now, just trying things. But the other pieces might be, the whole executive department, executive suite, whatever we call it. I was pretty good at bouncing a number of balls in the air at one time, and that all those balls fall much more often than they used to. And your slide on that is excellent on listing about what it covers for mild cognitive impairment.
And how has that affected your ability to work or your relationships?
I sold my company later in the year after being diagnosed. I was diagnosed in late 1999, my millennium gift, and I was going to sell the company sometime in that decade anyway, and I went ahead and sold it sooner rather than later. So it wasn't as critical. I don't know what it would have been like if I still tried to be in charge of 1,600 people, etc. Just got out nicely and graciously, but I just can't handle complexities and multitasking like I used to.
Dr. Goldman, I think a question on a lot of people's minds is this inevitable for everyone with Parkinson's? Do we know who will develop Parkinson's cognitive issues or dementia?
So that's a really excellent question, I think, very much on people's minds, and particularly when we talk about this topic, and something I think we all fear, as we age. Right now we can't fully predict who will develop cognitive changes, whether they're mild or more marked, like dementia. But much research is going on looking at predictors, which could be clinical factors, could be genetic factors, could be things like biomarkers or things we see that change on brain scans or in the blood or in the spinal fluid. So a lot of efforts to put those pieces together. But we know that these symptoms are common. They do affect a wide range of patients. And I think actually our field has really evolved in thinking about cognitive issues in Parkinson's. Many, many years ago, it wasn't even recognized that patients with Parkinson's could have cognitive troubles. So we've moved well beyond the thought that the symptoms are only motor and we need to address these non-motor and cognitive features. We've also grown to recognize that these cognitive changes can occur at different time points within Parkinson's. So there's studies that point to even patients when they're newly diagnosed or before even taking any sort of medicine for the Parkinson's may report trouble with it, very much like what George talked about, with trouble with paying attention or concentrating, like on a conversation or a book, or trying to multitask, and that some of these can be early, even around the time of the motor symptoms. We do know that many of these symptoms can progress, but not all. And I think one of the take-home points is that not all patients will develop cognitive trouble or dementia. So I think we need to figure out why some people are at more risk and others are not. But we know that they're... Oh, go ahead.
Could it be genetic? Do we know about how genetics may play into onset of cognitive impairment or dementia?
So the field of genetics is greatly emerging, and there are some genes that might be related to why some patients are at higher risk. So, for example, there's a type of gene mutation in a gene called GBA, which makes an enzyme that's involved in the different cells, and not only has been associated with Parkinson's itself, but also potentially with having more cognitive and behavioral issues. There's also another variant of a gene, so kind of a variation in the genetic code for a protein called tau, a gene called MAPT or MAPT, where some of those patients might be more likely to develop dementia. And I think a lot of these studies are emerging and take many patients to help uncover whether or not the genes are related to cognitive impairment.
Great. Jamie, what is research doing to learn more about who may develop PD dementia or the influence of factors like genetics?
Yeah, so there's a lot of work being done in this area, much of it funded by the Fox Foundation, I'm happy to say, including our PPMI observational study. And this is a large study that follows patients for 5 years, at least 5 years, and looks at a variety of different types of measures. So they're tested on different types of clinical and cognitive scales to see if they're impaired and to track impairment over time. They also have blood drawn and cerebral spinal fluid taken so that we can measure different types of genes and proteins in these fluids to see if there's an association between any of these things and what we see clinically and cognitively And if we can perhaps find something that puts somebody at risk for cognitive decline and that may be an early marker. Other tools that are used include different types of imaging. So MRI, for instance, may give us a clue as to which brain regions are involved, especially early on. We might be able to see changes on an MRI scan before a person has any kind of cognitive issues that may predict the onset later on. And then there's also different types of functional imaging, such as PET and SPECT, which allow us to look at different chemical systems in the brain that may also be related to cognition. But I think the real goal here is to understand which brain regions are involved so we get a better idea of how the brain is connected to what we see, the different types of symptoms we see. But if we can find early markers, ultimately we'd be able to treat patients very early on, which would be ideal.
So that brings us to our next slide. What is actually happening in the brain to cause cognitive decline? Jamie, what can you tell us about different proteins and those neurotransmitters?
Well, so we don't know completely what's causing the cognitive decline. We do believe that part of it is due to Lewy bodies, and this is really the pathological hallmark of Parkinson's disease. All Parkinson's disease patients have Lewy bodies in their brains, and these are deposits of a protein called alpha-synuclein, which you may have heard of. So these are essentially clumps of alpha-synuclein in the brain that interfere with function. And some patients will show more of these Lewy bodies in different areas of the brain than others. We think that cognitive impairment and particularly dementia is probably due to Lewy bodies in regions of the brain that are associated with cognitive functions, such as the cortex. But there's also changes that occur in a variety of chemical systems, neurotransmitter systems, that we know are important for cognitive function. So depending on which of those systems are affected, you may see different symptoms.
So what about these other proteins that play a role in Parkinson's and Alzheimer's? Does that mean that people have both diseases at once, Jamie?
There certainly are people who have both diseases at once. We know that both Alzheimer's disease and Parkinson's disease are associated with aging. That's the biggest risk factor for both of these diseases. So as we age, and Alzheimer's disease is far more common, so as we age, there's more and more a chance of accumulating the proteins associated with Alzheimer's disease in the brain. And this would include beta amyloid and tau. Again, these are proteins that clump in the brain and interfere with function. It's also possible that in patients with Parkinson's disease, they may have lower levels of these proteins, so not enough to actually cause Alzheimer's disease, but there may be an interaction between the pathology that's responsible for Parkinson's disease and the pathology that's responsible for Alzheimer's disease, and this could have sort of a synergistic effect.
So theoretically, could you use the same drug or medication to treat Parkinson's, dementia, and Alzheimer's?
It depends on what you're treating. If you're just treating the symptoms, we know that a lot of the symptoms in Parkinson's disease, both the mild cognitive impairment and dementia, overlap with what you see in Alzheimer's disease. So a symptomatic treatment that works in Alzheimer's disease may well work in Parkinson's dementia or Parkinson's MCI. If you're talking about a treatment that is aimed at being disease-modifying and essentially slowing or stopping the disease process, then it's less likely that a drug that affects Alzheimer's disease would be useful for Parkinson's disease, unless it was a case where you did have both diseases.
Gotcha. Let's talk about how we're treating cognitive decline and dementia and Parkinson's today. So we'll see on the next slide some available treatments. And Dr. Goldman, why don't you tell us about how you would approach treatment if someone came into your clinic showing some of these symptoms.
Sure. So, when I see patients in the clinic, sometimes the report will come from the patient that they feel like their thinking is different or has changed, or sometimes from concerned family members or caregivers or friends. And I think one of the very first step, even before jumping into treatment, is to get a good assessment of a patient's cognitive state. In a sense, it's actually very important to do, even from the early time of diagnosis, to have a baseline, much like the way we do even with motor function. And this can be done in a number of different ways. So certainly getting information from the person and talking to the family or people who come with them. But it also can include other more formal tests, which could be screening cognitive tests, tests that could be done even in the clinic or at the what we call at the bedside in the hospital, or more formally with comprehensive testing with a neuropsychologist to try to capture all the cognitive domains that we mentioned before, and to see where someone's at and see whether it's different from how they were 6 months prior, a year prior, 5 years prior, et cetera. So I think that's one of the first steps. Another thing that comes across my mind is really to distinguish whether or not the cognitive changes came on suddenly or whether this has been a gradual decline. Because medically that points us in sometimes two different directions. Very often when things are sudden, we try to exclude other reasons that someone might be having cognitive trouble, whether it could be a medical problem, a urinary tract infection, or a new medicine that they were put on for either Parkinson-related or a totally unrelated reason. So I think those are kind of the first steps in terms of evaluating cognition. And then depending on what we would find out, whether the cognitive troubles might be mild, whether or not they affect only one area versus multiple cognitive domains, or whether they're at the point that they're severe enough that they're impacting someone's daily life, which could be things relevant to their work, like George mentioned before, things at home, safety, driving, etc. So if someone meets the criteria and has deficits that are severe enough for Parkinson's disease dementia, right now the only FDA-approved medicine is rivastigmine, which works on acetylcholine. It's a cholinesterase inhibitor. It's also been approved for Alzheimer's disease. There are a number of other drugs for Alzheimer's that target similar mechanisms or other neurotransmitters that are approved for Alzheimer's but have also been studied in Parkinson's disease dementia. But I think also...
Sorry, I was just going to ask George to share his experience and how you've coped with the changes you've noticed, George, either pharmacologically or lifestyle changes.
Yeah, I've had the pharmaceutical side of it with, over time, the behavioral ones, the lifestyle ones I can have are more a direct result of the DBS, and I've had the cognitive issues came on earlier in my 15 years, earlier than it was hip and trendy to have those symptoms and to identify it with the Parkinson's or cognitive decline. Since I've had a year and a half ago when I had the DBS, it was great. I got relief on a number of factors and was expecting that it would level off after about 6 months, and mine doesn't seem to have declined anymore. might have even continued to get better. But I can just tell there's that different region where the problems are altogether different than motor skills. And not that I don't have the motor skill things also, but friends and whatnot.
Has the support of your family and loved ones really helped? We've got a question on what caregivers can do if their loved one starts to show symptoms of cognitive impairment. Can you share how your family and friends have helped support you?
Yeah, you got a good one on here on social activity. People don't realize how important some of that is, and the caregiver gets to come right in there and, friends and whatnot haven't cut me out of going to Packer games or Brewer games or golf or travel, and I'm not a lead weight, but I don't carry as much weight or thought or whatever, and it's so easy for a Parkinsonian to drift off and not socially engage as much, etc., and that's wrong. The person between the professional, the doctor that's involved, etc., the social activity comes along pretty strongly with all the rest of your life that you review.
Dr. Goldman, what do we know about how those lifestyle choices like social activity and exercise impact cognitive abilities?
Yeah, those are really important points that George brought up, because studies in aging have shown that being active and engaged socially, mentally, and physically are all beneficial and can help with healthy cognitive aging, if you will. So we think they are likely very important in Parkinson's too. Many studies are starting to look at this, whether they include physical activity or exercise regimens. Brain games are often very popular, and to really look scientifically as to how that affects cognition in terms of improving it or potentially even slowing any decline. So being active and healthy and positive are all really, really important aspects.
We see the word diet on the slide, and we get questions, we've gotten them in this hour, and I've heard them before, about the influence of diet proteins on the proteins in your brain. We associate protein with meats and fish. Does that have any impact on Parkinson's disease or its progression?
So the proteins that are ingested, from foods or other sources, are really a little bit different from the proteins that we talked about in the brain, or even the ones that clump together when they shouldn't. So it's not likely that what we eat protein-wise, we're seeing results or effects in the brain. However, that being said, there's been a lot of research looking at different types of diet in terms of cognition and healthy aging, with some studies pointing towards like Mediterranean diets and other kind of comprehensive and healthy diets potentially having effects on cognition or slowing decline. I think many of these will remain to be seen in Parkinson's, but there's some recent studies looking at this in aging. It's a very interesting question.
Very interesting. And so there's a lot of research going on about what contributes to these symptoms, but let's talk now about what therapies are in testing to treat the symptoms that are soon evolving. Jamie, we see a couple on these and different neurotransmitters. Can you take us through what's in the pipeline?
Yeah, so the Fox Foundation is currently supporting several projects to test different therapies. And as you see on the slide, one of them is called droxidopa, and this enhances the production of a neurotransmitter called norepinephrine that we think is involved in some aspects of cognition. We've talked about acetylcholine and how this is thought to be important in Alzheimer's disease. We also know that this system is affected in Parkinson's disease and probably is involved in some of the cognitive symptoms that are often seen. Donepezil is one drug that has been tested in both Alzheimer's disease and Parkinson's disease. There are other similar drugs, but they all affect this system. And then there are some more new drugs coming out that look at other neurotransmitter systems, such as the serotonin system. We're currently supporting a clinical trial for Parkinson's dementia using a drug that targets serotonin receptors. So these are all symptomatic treatments. They're aimed at improving the symptoms, but they wouldn't do anything most likely to change the progression of cognitive symptoms over time. So I think that our main goal here at the foundation is to find a cure for Parkinson's disease, and I think if we're able to achieve that goal, then we would be finding a cure for both the motor and non-motor symptoms, including cognitive symptoms. So that's the ultimate goal.
How are we doing towards that?
Well, I think we've made a lot of progress in the last, especially couple of years. There are several clinical trials now that are testing drugs that are aimed at slowing or stopping the progression of Parkinson's disease. And these are in early testing right now, but the fact that we have several that have just entered the clinic is really exciting, and I think gives us great hope for the next few years that we'll have something that will work.
We see, too, on the screen, deep brain stimulation. A lot of questions coming in about the impact of DBS on cognitive issues, and we see it may even be used to treat cognitive issues. Dr. Goldman, can you talk about that procedure and its impact on this symptom?
Yeah, so deep brain stimulation, or DBS, as it is often known, has been used to treat the motor symptoms of Parkinson's, whether they're tremor or helping people reduce their medicine load and reduce side effects like involuntary movements or dyskinesias. So there have been a number of large DBS trials trying to look at not only the motor benefit, but also what happens to other symptoms, such as cognition and mood. And that has raised some questions as to different targets in the brain that are used for DBS. One is the subthalamic nucleus, or STN, and the other is the globus pallidus interna, or GPI, that people might hear of. And whether or not DBS can affect patients' cognition in a potentially negative way, and whether that might differ in the different targets. So there's been some reports that patients after DBS have had changes in their ability to find words or generate what we call verbal fluency. Doesn't mean everyone, but it's come up in a couple trials, and that's why people are aiming to study this more and refine the targets and look at which patients might be best suited to which DBS target for the motor symptoms. And then I think one exciting aspect of the neurology and psychiatry fields are seeing the growth of DBS for neuropsychiatric symptoms, for depression, for mood, other aspects of mood, and even for cognition. So there's some very early studies looking at Alzheimer's and Parkinson's dementia to actually stimulate those areas of the brain, much like the DBS for the motor symptoms that are involved in thinking and memory. So I think we'll hear more about that as things evolve, but it's actually a really exciting to think that we'll have not only medicines, but potentially surgical treatments and non-pharmacological treatments to try to target cognitive impairment.
Fascinating. Yeah, there's a lot going on in DBS. We actually did a webinar, a whole hour devoted to all the new potentials in DBS in March. So if anyone's interested in listening to that, it's at michaeljfox.org/webinars. If you joined us late, I'll reintroduce myself. I'm obviously not our usual moderator, Dave Iverson. My name is Maggie McGuire, and I work at the Foundation in Research Communications. Dave can't be with us today, but we're trying our best to do well in his honor. And we've gone through a lot already, and I know that our audience has a lot of questions. So we're going to pivot and start answering some of those directly. You should see the Q&A box on your screen, and feel free to enter in there anything that you want us to talk about. So I'm going to dive in. Dr. Goldman, you just mentioned neuropsychiatric symptoms. Can you talk about hallucinations in Parkinson's and if this falls under the cognitive impairment umbrella?
So hallucinations are one of several different types of neuropsychiatric symptoms in Parkinson's, and they can range in terms of a spectrum from anything as mild as what we call an illusion, which would be a misperception of, say, looking at something, but it looks like it's something else, like a tree and looking like it's a lamppost or something like that, to visual hallucinations, which tend to be the most common that we encounter in Parkinson's, where someone might see something that is not really there. It could be a little animal scurrying around, a child, or it could be other figures that might not even be well formed or distinguished. Sometimes these can be even pleasant, so they're not always frightening or scary, but they can be attributed to probably a number of different reasons in Parkinson's, some of which could be medication related, some of which might go in tandem with cognitive issues or trouble with paying attention or trouble registering what one sees and what one processes in the brain to make sense of it. So often they go hand in hand with cognitive changes, but not necessarily so.
What about mood? A couple questions coming in asking if anxiety or depression and cognitive decline are related.
So mood symptoms, we've also come to realize in Parkinson's, are very common, and that previously, many years ago, were not really well recognized. And those can include mood symptoms such as depressed mood or anxiety, and can affect a number of patients. Very often they can occur unto themselves, but they can also occur as linked to cognitive symptoms. There's work being done to look at risk factors for cognitive changes, and some of those have even implicated whether having a history of depression could contribute to later cognitive changes, and whether things like anxiety or mood symptoms could have a relationship to different proteins in the brain and their accumulation, such as amyloid beta. But we often see them together, and I think an important aspect to consider is that there are also good treatments available for depression and anxiety symptoms. But your point about the neuropsychiatric is I think, a really important point of cognitive impairment, because we need to think about how cognition relates to all these other non-motor symptoms, whether it's mood, hallucinations, sleep, or apathy, and changes in behavior.
So you just said sleep, and we got a question on that too. How does sleep impact cognitive decline? Fewer hours have any effect on the brain?
Yeah, well, I can tell you that, not having a good night's sleep definitely takes its toll on the next day. I'm sure we can all attest to that in terms of sleepless nights. So, in fact, actually, as part of the evaluation for cognition, it's also important to ask about how someone is sleeping, how they're sleeping at night, which can frequently be fragmented or disrupted in Parkinson's, and how sleepy they are in the daytime. There have been some studies that point towards evidence that patients with cognitive impairment or dementia are sleepier during the daytime, and whether or not that's a chicken or an egg is sometimes hard to sort out, but there might be a real biological mechanism under it. There have also been some studies that have suggested that a sleep condition where patients act out their dreams, called REM behavior disorder, or RBD, which we know can be linked to the later development of Parkinson's or synuclein disorders, might have a relationship too with mild cognitive impairment.
George, a question for you. Someone asked, is there a pattern to the symptoms? Are they worse in the morning or maybe on an off day when your motor symptoms are acting up? Do you also see a difference in your ability to multitask or remember?
Yes, I do. How do I say this? Any day that I've goofed up and not taken one of my pills, like I take 4 carbidopa a day every 4 hours. I take one amantadine with that. I've got the neuro patch at 4.6, and I've got the Exelon at whatever it is. If I get off that by very much, and I can't believe I do it, but I completely forget my meds sometimes, or traveling or something, not have packed right or something, and I can really tell a difference. So not the long-range staying power by the half day if I make an error and you can't catch them right up. Everything's back. I mean, fatigue, several words work well for it. Fatigue, sleeping. I'll wake up almost hourly at night sometimes, and wake up almost every hour, and then the next day, you bet I need a nap at noon or 1 or 2 for 1 or 2 hours, and get my meds back on, and I'm in good shape again. Does that answer
Dr. Goldman? Oh, sorry. Thanks, George. Dr. Goldman, anything you can add about the patterns or occurrence of these symptoms as related to the day or other symptoms?
Yeah, that brings up a really good point that patients who have motor fluctuations, or what we call on and off periods, where on where the medicine's working well and off where it might be a low time or time before the next Parkinson medicine dose, can also experience what we call non-motor fluctuations. And while we've typically also thought of those as related to anxiety before the next dose, those can actually manifest as cognitive symptoms. So some patients will report that even within the cycle of their Parkinson's medicine dose, they may be, when they're on, thinking more clearly, but when they're off might be more fuzzy for different patients. So that's also important to ask at the clinic visit. The other point is that frequently when patients are having marked cognitive issues or dementia, they can experience something called sundowning, which tends to occur later in the afternoon or into the evening as the sun actually goes down and it gets dark, where they might be more confused or less lucid. So there's this kind of day-night time pattern or diurnal variation that sometimes we'll see.
Interesting. A question about medication. Do other medications cause cognitive symptoms, Dr. Goldman?
So medications are an important part of evaluating patients who are having trouble with cognition. So it's not uncommon that something, sneaks into someone's regimen that could have an effect on cognition. So many medicines, for different reasons, whether it's for pain or for bladder or to treat an infection or cardiac medicines actually can get into the brain. So not only do they get into the bloodstream and where they're supposed to go in the body, but some of them can get into the central nervous system, and therefore they can have effects on cognition or make people sleepy. So even Parkinson's medicines, some of them can make patients sleepy, and as we just talked a little bit about, can affect cognition. So having a really good review of what a person is taking and being prescribed can help sometimes eliminate some factors that are contributing to cognitive deficits. And not only just what's being prescribed, but even over-the-counter medicines or herbal medicines are worth taking a look at to see if any of those could be contributing to cognition. As a clinician, there are certain medicines if patients are older or having cognitive impairment or hallucinations, particularly ones that are like anticholinergics, may cause more cognitive deficits or confusion in those patients. So we try to avoid those when possible.
The drugs available for Parkinson's disease dementia, would they also treat mild cognitive impairment, or what other drugs would you use to treat someone who is not yet at dementia but does have some MCI, as we say?
So really great to point out, because I did say that only one medicine is FDA approved, and that has the indication for dementia. So right now it does not have an FDA indication for mild cognitive impairment. But with that said, some of these same medicines, like rivastigmine or donepezil and others, have been or are currently being studied for mild cognitive impairment, or MCI, and PD in Parkinson's disease. So I think even in the coming year, we'll likely know more as some of these trials have been completed and results become available. So for those medicines right now are indicated for dementia, but it really behooves us to have strategies, whether they're medication or non-pharmacologic, for treating the mild symptoms.
What about non-pharmacological approaches? We hear about those brain exercise games, whether it's Luminosity online or even some of the Parkinson's apps like Empower have games in them to stretch your brain. Any utility in those?
So, there is that old saying, use it or lose it for both mental and physical activity. And, well, I'm not sure we know that yet scientifically in terms of rigorous studies. It's very important to keep active and to be positive on that front and engage in these activities. There's some smaller studies that suggest some of them might be able to help people either learn new skills or improve specific elements of cognition, such as improving attention or improving memory retention or planning abilities. So I think there's more to come, but there's a lot of interest in those sorts of games and computer games.
And they're fun. Hey, George, a question about caregivers and what people who have a loved one who may not be willing to admit that they're having some cognitive issues can do, either to get them to care or just be more self-aware. Anything you can offer on what someone could do or say with their loved one?
I think they've got to take a look at what's going on around where they used to go that they're not going anymore, or who they're.
Hey, George, can I ask you to speak up a little bit? I know it's hard with.
Nope,
with
no
the
problem.
Thanks.
I think the patient, the Parkinsonian, has to take a look around at what they used to do that they're not doing now and see if they dropped it prematurely, and that could involve exercise. points of landmarks, points of interest, little family favorite places, ball games, grandchildren's sports and such as that, just good stuff. There's a trend where people, friends of mine that have got Parkinson's also have a tendency to cut back on things that they actually should increase on, specifically exercise. But looking around at the natural environment, so it's not too hard to do. They did it yesterday. They could do it today. And I think the caregiver, if they don't convince of that, won't be, the caregiver becomes the next one that's tired and run down and whatnot if they don't get some time off and have somebody else spend the time with the Parkinsonian.
That's important. Dr. Goldman, anything you can add about what someone listening who has a loved one maybe facing cognitive impairment can do?
Well, one thing that comes to mind is patience. So not patience as in with a TS, but patience, PATIENCE, in allowing time for someone to respond to questions. Sometimes patients will do better when they're given choices, so even choices that are yes, no, or examples. We even know this from different memory tests that Parkinson's patients who are having some cognitive difficulties do better when they can recognize something than have to freely come up with it off the top of their head. Patience and finding the right words and really recognizing that the person is still the person who they are. And there are many good caregiver resources available in various communities, online, even in medical centers, whether they're support groups or chat rooms or other things that are available. So I would encourage people to look and see what's out there, take advantage of them, even if they might not be directly related to Parkinson's, but dealing with cognitive impairment, there may be tips of wisdom from even the Alzheimer's field and other things that come to mind that are important are working with medications. Patients can be sometimes on very complicated Parkinson drug regimens, so making sure someone's not under or overdosing and having different reminders for them and different schemes for that would also be very important. I think we mentioned driving a little bit earlier, but things like that where safety is involved are critical.
Jamie, a question for you. There are a lot of medications for the motor symptoms of Parkinson's. Why are the non-motor symptoms and cognitive impairment so difficult to develop drugs for?
Yeah, well, I think we've touched on it a little while talking about the different neurotransmitter systems that we think are involved, and there are multiple chemical systems in the brain that are involved in cognition. And we've also talked about the variety of symptoms that we see. Cognition is pretty complicated. So to think that we could develop a drug that affects all those systems in the right way, that's a difficult task. So many of the drugs that have been developed thus far target a single neurotransmitter system. And that may help with some of the symptoms, but it's unlikely that it would help with all of them. There are some approaches that are sort of aimed at enhancing brain activity overall and that would affect multiple chemical systems, but to date, none of those approaches have been particularly effective. Although, there are still many companies and investigators pursuing those types of approaches. But I think in one sentence, the answer would be cognition is really complicated and the brain is really complicated.
Thanks. Transitioning back to clinical care and what we can do today, Dr. Goldman, some questions on supplements and vitamins.
So, Many patients, if they are eating a healthy diet, don't necessarily need added supplements or vitamins. Right now, there's no clear evidence for certain types of vitamins to help with mild cognitive impairment or dementia. Some of this literature has been looked at over many years, and sometimes that pendulum swings one direction and then swings the other, either in favor or not in favor of different vitamins and supplements. Though someone should be also careful to take a look at what's in some of those supplements and whether or not they could potentially interact with other Parkinson medicines. So, of course, that would be something to ask one's own doctor about, whether that could be indicated for another reason, but the jury is still out on many of the cognitive aspects for those.
Got it. Another question on what doctor someone should see. Should they see a neurologist, or should they see a psychiatrist or a psychologist for their Parkinson's cognitive impairment?
So if someone has Parkinson's and has shown signs or indications that cognition might be affected, it may be very helpful to see their neurologist or movement disorder specialist to take a look at the whole Parkinson's picture comprehensively. Many Parkinson's specialists have also focused on non-motor symptoms or behavioral aspects, so that's actually been a really big growth area in the field of movement disorders. When patients have a number of different problems that they're facing, sometimes having multiple doctors can help sort out some of those issues. So centers vary. So in some centers, the psychiatrists focus more on mood, like depression and anxiety and other mood symptoms, rather than cognition, whereas in some centers, psychiatrists also will focus on dementia, psychosis, or other aspects of behavior. So it may vary, but I guess the take-home point would be that subspecialty care with a neurologist and a movement disorder specialist might be a really good starting place. Having a neuropsychologist is often the person who does more comprehensive testing of thinking and cognitive domains. So sometimes seeing someone for a formal evaluation may be very helpful too.
Jamie, will everyone who gets some sort of mild cognitive impairment go on to develop Parkinson's disease dementia?
Yeah, this is a really good question, and I know that people worry all the time that if they have some degree of cognitive impairment, that they will inevitably eventually develop dementia. And it's really not the case. We know that many Parkinson's patients will experience some degree of cognitive impairment, and some of it may just be sort of a slowness of thinking. They can still do the task, they just can't do it as quickly anymore. And there's a great variety of symptoms that patients experience as well. So every patient is different, and while some will progress to dementia eventually, many will not. And I think it's important that we do develop treatments for the milder forms of cognitive impairment as well as dementia, because I think if we can improve function in patients who have a milder degree of impairment, that will really increase their productivity at work, probably enable them to work longer, and really enhance their quality of life.
It's a great takeaway. And as we wind down our hour, Jamie, anything you want to end on, have our audience know before we sign off?
I guess just speaking as a representative of the Michael J. Fox Foundation, I would just like to assure everyone that this is a priority for us. Of course, the top priority, I've said it before, is to find a cure for Parkinson's disease. But we are working on several new treatments for cognitive impairment, and we have different studies also that are just looking at the underlying mechanisms, so trying to understand it better and maybe come up with new ways that we can treat cognitive impairment.
Dr. Goldman, any last words?
So first of all, thank you again for having me participate in this. And it's a really exciting and positive time to be a clinician and researcher in the field and working, as Jamie said, to cure Parkinson's and slow down cognitive changes and treat them better. And I really am optimistic that we will see this happen. And there's so much growth in addressing these cognitive needs that I think together we will get there.
And George, anything from you for your fellow Parkinsonians, as you've called them?
We're excited about all the effort that's being given to the cognitive side now, and people had predicted we'd get there, and we have. It's very exciting, and us patients are running out of patience. Love it. Thank you, guys.
Thank you, and thank you three for being with us, and thanks to everyone for tuning in, especially as I've tried to fill the very big shoes of our usual moderator, Dave Iverson. So we'll send a link to the webinar on demand via email. You can listen again or share as you'd like. There's a survey link in your resource list, and we hope you'll share your thoughts on today's presentation. Mark your calendars for our next Thursday's webinar. It's September 17th at 12 noon Eastern, where we'll discuss sexual dysfunction and Parkinson's. Finally, if you're on Twitter, join us tomorrow at 12 noon Eastern for the hashtag FoxPD chat. Thanks everyone again, and have a great day.